Welcome. It's a delight to welcome you to the third of our COVID talks with Dr. Meg Fisher. This is, again, a critical topic that we've been discussing for obviously a year and a half now, and periodically it seems like it's useful to have the community able to ask questions of an expert that we have relied on to help us through these really challenging times. So hope you had a wonderful weekend. Again, we're delighted to welcome you this morning. We will actually make this recording or a recording available to anyone who was not able to be on this call today. So again, I thought I'd start by answering some questions, fielding a few questions related to school policy. And again, I will let Dr. Fisher answer a lot of the questions as they pertain to the medicine and the science that we're following. But I thought I would at least begin with some general questions that came in relation to the talk. So the question came up, who sets safety and quarantine policy for RANI? And again, it is a collaborative effort, certainly, as it is in all, I think, good institutions. We have the counsel of a strong board of trustees, but we're also very fortunate to have an expert group of doctors, professionals, researchers on RANI's medical advisory board, and we have certainly found them to be a critical touchstone to lead us safely through these times. The board and the medical advisory board offer counsel to me, but especially to the leadership team. As you can imagine, in a school like this, decisions are made by the administration generally, by leadership. We have regular meetings and regular discussions, but ultimately I am the one who approves policy when it comes to these areas. There was a question about the board of trustees, and again, I think more generally, and this is probably something we need to focus on in a different presentation, sort of what is the role of the board as it pertains to these and other issues. And again, I would just give you a quick governance 101, I guess, for independent schools to say that the board's role is to help set the strategic vision of RANI and other schools like ours, and to marshal resources. As a 501c3, we have special designation that we'll talk about a little bit later on in the presentation, but the board approves and stewards the mission of the school, strategic planning, the annual budget, and tuition changes. The board does not set operational policies or hire or fire faculty and staff or get involved in daily operations of the school. Similarly, the medical advisory board doesn't set safety and quarantine policy. However, the medical advice, again, has been instrumental in guiding us over these past 18 months. The COVID response team is an internal task force comprised of school administrators, the leadership team, nurses, counselors, and faculty representatives from each division. We meet regularly on at least a weekly basis to discuss protocols and have updates on what's going on campus as it pertains to the pandemic. Again, just briefly reflecting back to last year, for those of you who aren't new to the school, who were with us last year. Again, we're very proud of the fact that we were able to have a live 5-day-a-week schedule last year that allowed for flexibility and distance learning, and that we achieved 0 confirmed cases of on-campus transmission last year. So this year, as we began to put together our protocols, we certainly wanted to keep some of the same things in place. And you can see some of the things that we did in the past year, upgrading HVAC systems, a new regimen for cleaning and disinfection, routine COVID testing for faculty and staff, etc. For this year, I want to speak to the philosophical approach, which I think is most important, and everything else is really predicated on it. And that is that we have 2 goals. The first and foremost is to keep faculty, students, staff, and families safe. That is clearly one of the 2 main goals. The second is to minimize disruption to students' academic and student life experience. And again, thus far in the year, we have seen a real testament to the success of that, in that we have had 2 very small quarantines that did not disrupt the campus life. And we have also seen 99% of our students here on a regular basis, as opposed to last year when there was certainly a lot more students availing themselves of the virtual option. As you can probably imagine, we have received vocal feedback on both sides of every issue as it pertains to protocols and the virus: masks, vaccines, quarantine policies. And I guess if I were to put it in a way that defines what our strategic goal is, or tactical goal on this, it's to stick to a middle ground. We are not on either extreme in terms of these issues. Because we were so successful in keeping the community safe last year, we have felt more comfortable in having a more surgical approach this year in relation to quarantine. The CDC and the NJ Department of Health recommend quarantining close contacts rather than whole classrooms, and that has certainly been our experience thus far in the year. Close contacts, as I'm sure you already know, are defined as those within a 6-foot radius of someone suspected or known to have COVID-19 for 15 minutes in a 24-hour period. We had 2 cases, as I said, so far that we've reported out on. One was an upper school case, and certainly though we don't like to have any students out for a quarantine, I think it is really notable that the number of students affected was a grand total of 6. Those are limited to unvaccinated close contacts of the student who is infected. And again, as we'll speak to later on in terms of quarantine policy, there is clearly an advantage to students who are vaccinated in terms of the CDC and NJ Department of Health recommendations on quarantine, that even if they are in that radius, they are not expected to be quarantined. We had a lower school case that resulted in 8 students who were in quarantine, again, close contacts. So what scientific evidence supports the masking requirement? I will certainly defer to Dr. Meg Fisher on this, and I'm sure she'll be able to cite specific studies that reinforce the notion of the safety of masking. However, I want to be really clear that we see this masking as one valuable component of risk mitigation, just as we did last year. This policy has the support of the CDC, the American Academy of Pediatrics, and many others. Our protocol requiring masks, though, was clearly preempted by necessary compliance with the governor's executive order 251. Again, we've communicated many times about this already, but I just want to reiterate that. The language of the EO specifically references the fact that it applies to all schools, including independent schools. The EO was very specifically written that way: public, private, charter, and independent schools. Masking orders and protocols have also been shared numerous times, but these include universal indoor masking with certain very narrow exceptions, like lunch, for example, or really strenuous indoor activity, PE. Outdoors, children and adults are free to unmask. And again, that policy began to change, and Dr. Fisher can speak more to that, but that policy began to change in the spring of last year, and certainly that remains the case. So we've been able to have a lot of outside events. We had a wonderful senior vesting ceremony, which we did on the front lawn. We have a cocktail party, a welcome back on Thursday, and we feel very comfortable with that context, having children or adults unmasked outdoors. Again, in terms of the context of an independent school and the executive orders, what does independent mean in this context? We are not dependent on tax dollars or district funding. As I said, we are an independent 501c3 organization. That's the tax status. We're operated by an independent, self-perpetuating board of trustees rather than a local school board. Again, a huge distinction between us and public schools. And we have independence in setting a number of areas like curricula, but there are certainly rules and regulations and safety protocols that apply to us, not only in this COVID context, but for example, in other safety drills, in fire drills, in active shooter drills. There is compliance with those as well. So I just want to emphasize that being independent does not mean that we are exempt from following executive orders, like Executive Order 251. Again, you're probably aware of the other executive order as it pertains to schools, all schools, and certainly RANI, and that was Executive Order 253, and that required all preschools, and again, recently that changed from 2 years up, by the way, but all preschools and schools through grade 12 for all school personnel to be either fully vaccinated against COVID-19 with a certain date of compliance, or to comply with testing on at least 1 time a week basis. RENI certainly is also in compliance with that rule, which again has the force of law, and that is that currently 90% of our faculty and staff are vaccinated. Unvaccinated faculty and staff are complying with the weekly testing requirement, which has gone very well, very smoothly so far. And again, over the summer, and actually we announced this at the end of last year, we wanted to make sure we incentivized faculty in a positive way and employees. So we did offer an incentive to those who vaccinated. As it turned out, a huge percentage of folks had already availed themselves of that option prior to our start this year, when the rest of folks either submitted vaccination status or again are complying with weekly testing. I want to be clear about vaccination. There is currently no mandate requiring students to vaccinate, and we have at this point no plans to implement that policy in the foreseeable future, barring a mandate. Some have asked why we wouldn't mandate vaccination. And again, I want to be very clear, we certainly have strong voices on both sides of this issue. But I think particularly since, although I think this will change in the coming weeks, the vaccines, Pfizer is not even available to those under 12. And therefore, clearly for our younger middle-aged middle school students, and obviously all of our early childhood and lower school students, they wouldn't even have the access to that. And certainly parents have strong views on this. And at this point, we are not in a position where we have plans for a mandate, though again, we certainly have no idea what the state will ultimately do, either in the shorter or the longer term. We do hope the fact that being vaccinated means, as I said, that individuals can be exempt from quarantine is certainly an incentive, and again, helps with risk mitigation, because it's very clear the vaccination is a clear piece, a large piece, significant piece of that risk mitigation. Again, we'll continue to look at other options for risk mitigation. We meet regularly, routinely, and we look at the conditions on the ground, not only in the state of New Jersey in general and vis-a-vis our peer schools, but also very locally. So there could be a point at which, for example, we decide to add another layer of risk mitigation, like regular testing, for those who are unvaccinated. So that's a possibility. It's certainly something that we have not immediate plans to do. We haven't moved on, but certainly it remains a possibility for us, depending on conditions on the ground, and again, safety and health of the community, all stakeholders being the preeminent concern. I wanted to share, since this came up as a question, where we are in student vaccination. And again, you'll see two different numbers or ways of parsing the numbers. So for the upper school, we have had, as you can see, a little over 200 of our students submit vaccination, or parents submit vaccination records. That is 56% of the upper school community. We have 8% not yet vaccinated. Of those, again, who've answered these questions, 6% prefer not to disclose, 3% of the total prefer not to vaccinate, and 27%, or just under 100 students or parents, have not yet responded to that. So again, it's hard to know what that means, but certainly we are beginning to move in the right direction. I think, I would hope as the fall goes on and the rest of the year, those numbers would grow. And again, so 77% of vaccinated respondents to the survey. Middle school, probably as you would expect, maybe you're not surprised by this, the numbers are a little lower at 44%. Or 56 students total, and I won't read through all those numbers with you, but obviously you can clearly see where we are in all of those numbers as well. So I think those are the main questions that I have as they pertain to specific policies of the school, although we'll certainly keep track of those, and Jennifer Collins, who's moderating this discussion, will certainly recur to other questions if they come up, and I'd be happy to answer those. But at this point, I want to turn the program over to our expert, Meg Fisher. Dr. Fisher, as I think you know, if you have been on these talks before, is a world-renowned pediatric infectious disease consultant currently advising the New Jersey Department of Health as it pertains, again, to COVID-19 and the pandemic. She served as the medical director of Underberg Children's Hospital, and as chair of the Department of Pediatrics at Monmouth Medical Center. She is an expert with over 150 peer-reviewed articles, chapters, books, abstracts, and other publications under her belt and to her credit. So we could not be more delighted and grateful to her for all of the advice and help over the past year and a half, negotiating and navigating these really difficult issues for all schools, Rennie included. And so with that, I'll turn the questions over to Meg Fisher. Thank you. Thanks, Dr. Fisher.
Thank you. It's a pleasure to be here with you.
Dr. Fisher, I will share my screen with your presentation.
Okay. All right. So what I'd like to do in the next few minutes is really give you a little bit of update of where we are with this disease and talk about the vaccines and why you should get them. So if we could, can you go back one? Okay, so this is my disclaimer. I always start with a disclaimer because the information about this disease and about the virus really is evolving daily, and our recommendations are changing very frequently. For those of you who remember last week, at the end of the week, the CDC and the FDA approved of Pfizer boosters. So those are brand new. So we'll talk about what's happening with these vaccines and what you need to know. But let's start with some basics about the disease. So we go to the next one. We know that the name given to the disease is COVID-19. It stands for coronavirus infection, and the outbreak started in 2019. The virus that causes it is called SARS-CoV-2. And we now know that this disease is primarily spread by droplets. Occasionally, it can be airborne, but most of the time it's by droplets. So what are droplets? Those are those little particles of spit that you make when you talk, when you yell, when you sing, etc. And those go out into the air. Now, most of those droplets will fall to the ground within 3 to 6 feet. And if we look at the next slide, this is a picture of someone sneezing. And what I want you to notice is there's a lot of droplets there, but most of them are falling down to the ground here within 3 to 6 feet. Granted, a few droplets may stay airborne, and that may be what leads to these super spreader events where there is evidence of airborne transmission. But most of the time, transmission is by these droplets. Now, if that's the case, then we know how we can protect ourselves. And on the next slide, you can see wearing a mask that covers your nose and your mouth. So putting the mask on means all the droplets you're making are going into the mask, not into the air. So you're protecting others because remember, you're not going to always know what infections you have. And this actually protects you not only against COVID-19, but influenza, respiratory syncytial virus, the common cold viruses. All those droplets are going to go into the mask, not into the air. Also, when you're wearing a mask, the air that you're breathing in is filtered by that mask so that any droplets that were in the air that you're exposed to would get filtered out by the mask. So very inexpensive, great way to protect people. And multiple studies now have shown that masks are effective, that schools that are using masks and distancing have not had trouble with outbreaks. So very clear evidence that masks are helpful. We also want people to stay at least 6 feet apart. And for school, we know that 3 feet for children appears to be as safe as 6 feet. And again, this is to avoid those droplets. The other thing we want to do is avoid crowds and sick people. And then, of course, we want you to get vaccinated. And hand washing is always something we're going to tell you to do. It turns out that the COVID-19 virus is not really spread on surfaces very well, but other viruses are. Things like influenza, et cetera, are. So we want you to wash your hands often and, of course, get vaccinated when you can. So the next slide is going to show you what's happening with COVID-19 cases in the US and then in New Jersey. And you can see that the good news is it looks like this recent surge is beginning to drop off. We see that across the country. In New Jersey, we're kind of flat. We haven't started to really drop off yet, but at least we've stopped that dramatic rise. So this is good news, but we know that this virus is not going to go away for a long time. So the next slide talks about what diseases we can get. So you can be infected with this virus and have absolutely no symptoms at all. You don't even know you're infected. Or you can have a little mild cold, or you can have severe disease with pneumonia and then involvement of other organs and finally even death. To date, there have been 684,884 deaths across the United States. and 24,429 in New Jersey. And these are confirmed deaths. So clearly, we're not out of this yet. We're still seeing about 10 to 20 deaths a day in New Jersey. So very important that we try to stem this epidemic. We know that children usually don't have any symptoms at all, or they have fairly mild disease, but not always, particularly children who have underlying problems. So there have been about 460 deaths in the United States and 9 deaths in children in New Jersey. We also have this very odd multi-system inflammatory syndrome in children. This occurs about a month after a child's been infected, and the immune system just kind of goes berserk and starts to act against the child instead of just against the virus. This can result in shock. Children usually will require intensive care. And the good news is, fortunately, almost all children survive and actually do quite well, but it can take some time. Across the United States, there have been almost 5,000 cases and 41 deaths. In New Jersey, we've had 133 cases reported so far, and fortunately, no deaths. The next slide talks about post-COVID conditions. And you may have heard about this long COVID or long haul COVID or post-acute COVID. And these are people who got infected and just are not getting better. So a month later, they still have these symptoms: difficulty breathing, they're tired, they're fatigued, they have cough, they have pain in their chest, they have pain in their joints, pain in their head, palpitations. And all of these symptoms tend to be worse after activity. And of course, they're tired and fatigued. They have a pins and needles feeling in their extremities. They have diarrhea, sleep problems, rashes. They're dizzy when they get up. They may have fever. There are changes in their mood. Their taste and smell may change. And they may have changes in their menstrual cycle. And then, very upsetting, is this brain fog. They have difficulty concentrating. They can't do their homework like they used to be able to do their homework. They're just not back to their normal self. How common is this? In the adult studies, somewhere around 30, and in some series as many as half of adults with COVID have long COVID. They don't recover even after a month of getting over those acute symptoms. They still have a variety of these other symptoms. In children, we think it's less common, but it is somewhere around 10 to 20% of children can have very similar symptoms. And we're really trying to learn more about this. We don't know exactly how to manage it. We also know that some children will have those multi-organ system effects we talked about, where your immune system just acts against you. And then people who require intensive care, there's a post-intensive care syndrome where people have weakness, again, that brain fog, but also post-traumatic stress disorder. Next one. So clearly, COVID-19 is a disease we'd like to prevent, and we have vaccines to do that. They're safe, they're effective, and they're free. So let's talk about those vaccines. Next one. The messenger RNA vaccines include the Pfizer and Moderna vaccine, and the adenovirus vector is the J&J or Janssen vaccine. There's also an AstraZeneca adenovirus vector, but that's not available in the US, but it is used widely throughout the rest of the world. So for these messenger RNA vaccines, Pfizer was the first to get an emergency use authorization. That was in the middle of December in 2020. And at that point, it was authorized for ages 16 and older. In May of 2021, the emergency use authorization was expanded down to age 12. And in August, on August 23rd, Pfizer became the first COVID vaccine to be fully licensed. And then it got a new name, but it's exactly the same vaccine. Moderna received their emergency use authorization about a week after Pfizer, and they are just for ages 18 and older, but they have submitted information about expanding them down to age 12, and they are also beginning to apply for boosters. And I didn't note that on here. I should have updated this slide. The booster dose was just authorized literally last week. As far as the adenovirus vector, the J&J vaccine was got its emergency use authorization the end of February, and it again is just for ages 18 and older. And it is also, that company has also looked at the possible need for a booster vaccine, and you'll hear about that probably in the near future. Next slide. So how do these messenger RNA vaccines work? Well, the messenger RNA is simply a code. It tells a cell how to make a protein. And in this case, that protein is the spike protein, the little spike that's on the outside of this coronavirus. And what the vaccine does is it takes that messenger RNA and it puts it into a little blob of fat, a lipid nanoparticle. That fat allows the messenger RNA to get into the cells. And once it gets into cells, the code is read and the spike protein's made. Now, that spike protein is not a human protein, so the body responds with both antibodies and cell-mediated immunity to make a response against that spike protein. If you have a response against the spike protein, then the virus cannot make you sick because it can't get onto your receptors in your body because all the spike protein is covered by those antibodies. For the messenger RNA, it's a 2-dose series, and it's not maybe boosters. For Pfizer, it's definitely boosters, and Moderna is also working on a booster. Pfizer's booster is the same as the original dose. Moderna's booster is a lower dose, and it's not yet authorized, whereas Pfizer's is. The next slide tells you about the J&J vaccine. The J&J vaccine is this adenovirus vector. So you take that code, that little code of how to make the spike protein, and instead of putting it into a glob of fat, you put it into another virus. And in this case, it's an altered human adenovirus that's altered so it can't make you sick. It doesn't multiply. Just you get in, it enters the cells, it releases that code, the protein is read, the protein is made rather, and the immune system reacts to the protein same way as it does with the messenger RNA. Right now, this is a single dose, but J&J has also looked at booster doses, and it is likely that within the next few months, we will have a booster dose for J&J as well. Next slide. So what are the major side effects? Well, the most common side effects are simply pain where you got the shot and this kind of achy feeling, fever, headache. And these are the common side effects with any vaccine. We know that the risk for severe reaction is very, very low. We know, though, that people who have a history of anaphylaxis, severe allergies to either foods or medicines, may have a reaction to the messenger RNA vaccines, but those reactions are very treatable. We also know side effects are less common in people over 50 years of age, and unfortunately more common after the second dose. Next slide. Now, it was noted pretty early on that there was more than the expected amount of anaphylaxis, severe allergic reactions to both Pfizer and Moderna. So these are the results of the early studies showing that there were about 11 cases per million for Pfizer and about 2 cases per million for Moderna. And generally, we expect anaphylaxis about 1 per million of other vaccines. So because of this, well, the next thing that was noted is almost all of these reactions were within 15 minutes of the vaccination, and almost all were in women. And most of the people who had a reaction had a history of allergic reactions. So because of this, the recommendations on the next slide are that every place that gives the vaccine should be able to handle anaphylaxis. And the way you do that is you have epinephrine in the syringes. So you have EpiPens available. And you need the people to recognize an allergic reaction and go ahead and treat it if necessary. Also, people who have a history of anaphylaxis should be watched for 30 minutes instead of the usual 15 minutes. And then treatment is started with the epinephrine, and people are referred to get medical help if they do have an allergic reactions. These are very treatable. And then all adverse events should be reported to the VAERS system. Next one. The next thing that was noted about these messenger RNA vaccines was that a small number of people, almost always adolescents and young adults, almost always males, had inflammation of the heart, so myocarditis, or inflammation of the sac that the heart sits in, pericarditis. This was noted usually after the second dose, within 3 or 4 days of the second dose, and the patients presented with pain in their chest, and when their blood was tested, they did have elevation of the troponins of the heart muscle. So what's different, though, is this myocarditis and pericarditis was very, very short, very self-limited, and these patients did extremely well with just simple medications like ibuprofen, and they recovered usually within a day. So this clearly is a frightening thing, but we also know that the virus, COVID-19, causes myocarditis and pericarditis, and the Centers for Disease Control and the advisory committee looked at all this information and said, you know, the risk of the disease is way higher than the small chance that you'll have this inflammatory response. So that's where we are with the myocarditis and pericarditis. We know that it occurs, but rarely. And we really feel that children should be immunized as soon as possible to prevent them from getting COVID-19 and all those other problems you can get after COVID-19. Next slide. Now, the J&J vaccine also has some side effects. Common ones are common, same as if you get any shot. And they're less common in older people. And because this is a single dose vaccine, they're less common than with the messenger RNA. However, there's some serious side effects. The serious side effect with the J&J vaccine, on the next slide, is this low platelet count, thrombocytopenia, and clotting, thrombosis. And what was noticed is that a very, very small number of people who get this vaccine make an antibody against platelets, in addition to their antibody against the spike protein. And that antibody against the platelets causes the platelets to be low and causes clotting. And unfortunately, these clots are in the surface of the brain, they can be in the lungs, they can be in the abdomen, and they can cause very serious disease. This is treatable. It happens usually about a week to 2 weeks after the vaccine, and it's treated by giving a blocking antibody. So intravenous gamma globulin to block this antibody, and along with treatment for the thrombosis. Next slide. So because of the recognition of that problem, there was actually a pause on using the J&J vaccine. It was paused from April 13th until April 23rd. April 23rd, they analyzed all the information. They said the number of cases is very, very small. And again, the benefits of protecting people against COVID-19 far outweigh this small risk. So after the 23rd, J&J went back on the market, and vaccinees were reminded to seek medical treatment urgently if they had any of these signs that they might have a clot. And then healthcare providers were provided with this information so they would be ready to manage it should it occur. Next one. The other thing that came up in July, again, this is about 5 months after J&J came on the market, it was realized that there had been 100 cases of Guillain-Barré syndrome. And Guillain-Barré syndrome is an unusual neurologic problem where you get weakness that starts in your toes and moves up your body. Sometimes it gets as high as the diaphragm, and in that case, you need help breathing. It's almost always self-limited. There is treatment, and people generally recover fully. The incidence of this is slightly higher after J&J than the baseline incidence of the disease. So because of that, the FDA added a warning to the Johnson & Johnson or Janssen emergency use authorization fact sheet to let people know that this does seem to occur a bit more than expected following the J&J vaccine. Next slide. Now, those are the actual side effects of the vaccine. Fertility is not a problem in people who are vaccinated. We know that there is no evidence of any effect of COVID-19 vaccines on either male or female fertility. So there have been a lot of rumors about this, but there is no clinical evidence and there's no biologic reason to expect that there would be a problem with fertility. So the American College of Obstetricians and Gynecologists and the Centers for Disease Control and Prevention recommend that the vaccine should be given to all eligible people, those who may consider future pregnancies, as well as all pregnant and breastfeeding women. So there's no need to be concerned about fertility in young adults or in older adults who are getting vaccinated. Next slide. Now, what's really changed things are the outbreaks of these variants. So as viruses multiply, they change their genetic material and these variant viruses appear. Now, if a variant virus is a disadvantage to the virus, then that variant will go away quickly. But if the variant virus gives the virus a benefit, then that variant is likely to become the major variant circulating. So we have variants of interest in which there's changes in the virus that might increase their illness and transmission. We have variants of concern where there's definitely an increase in the transmission and illness. And then variants of high consequences where the virus is no longer susceptible to the usual things we do. Fortunately, we don't yet have any variants of high consequence, but we do have variants of concern. The Alpha variant originated in the United Kingdom, the Beta variant in South Africa, the Delta variant in India, and the Gamma variant in Brazil and Japan. And the next slide shows you what happens with these variants over time. So here's the whole United States, and this goes back to June. And in June, there was about half and half Alpha variant versus Delta variant. And since then, the Delta variant has really taken over, and just about 99% of all circulating viruses are Delta. Now, here's New Jersey, and New Jersey goes all the way back to December. And what you can see is we had, a few different kinds of variants. And then we began to see the Alpha variant increase. And then the Delta variant came in. And again, the Delta variant has just taken over, so that during our last weekly surveillance, 100% of the variants, or 100% of the viruses checked in New Jersey were this Delta variant. Next slide. Now, where should you go to get the vaccine or to get information about the vaccine? Well, this is the call-in number. There are people there who speak a variety of different languages, and they can answer your questions, help you get an appointment, and tell you where the vaccine is available. If we go to the next slide, if you're more comfortable with computers, you go to the vaccine hub, and you just click on New Jersey Vaccine Appointment Finder, and it will tell you where and which vaccine is available at your local pharmacies, at hospitals, at local health departments, et cetera. So the next slide will show you how we're doing so far in New Jersey. We've given 12 million doses of vaccine in New Jersey, and we have 5.6 million people fully vaccinated. Those are vaccinated at New Jersey sites. And then if we include our out-of-state vaccinees, we're up to 5.8%. And that, it gets us over 70% of the population. In fact, about 82% of our population has received one dose and 73% are fully immunized. The next slide shows you by age. And if we look at this, I'm very excited that the older population is highly immunized. So for people 65 plus, 96% of them have gotten one dose, 89% have gotten both doses. But as the younger group, as we look at the younger group, you'll see we haven't immunized as many of the younger people. Now that makes sense because the vaccine just came out for 12 to 15 in May. So we haven't had that much time, but we're New Jersey wise, about 55% of our people 12 to 15 are immunized. Interesting, that's very close to your number at Rana, or at least the number of the people who responded. So you can see that we could do better in these younger age groups, and also in college students, we definitely could do better. Next slide. Now, a lot of people ask about, well, isn't natural immunity better than vaccine immunity? And basically, there are more unknowns here than there are knowns. We honestly don't know if natural vaccine immunity will last forever. We don't expect it will. We know that anecdotally, most people who got sick in last April didn't get sick again this April, but some did. There were definitely some cases in people who had natural immunity. We also know that vaccine immunity isn't forever. It's solid certainly for 3 months, and actually now we know for 6 months. And if you look at protection against hospitalization and death, all 3 vaccines are good for at least 9 months. But, and right now, immunity against the known variants is solid. They're good for all the variants we know. But we don't know how long this immunity is going to last. And for that reason, it is recommended that even if you have natural immunity, you go ahead and get vaccinated to boost that immunity and hopefully to broaden your immunity to all of the variants. If we go to the next slide, this talks about booster doses, and this is truly hot off the presses. If you received the Pfizer vaccine and you are 6 months after your second dose and you're 18 years or older, and you may ask why 18? That's because that's the way Pfizer tested it. So this is only for people 18 and older, only for people who got Pfizer the first time, and only for people who are 6 months after their second dose of Pfizer. Booster doses should be given to people who are 65 years of age and older, because their immune systems, aren't quite as good as the younger people. So we want to protect them, and we know they're at higher risk. We also want to give it to people who are 18 and older living in long-term care, because we know we have outbreaks in long-term care. We also want to give it to people between the ages of 50 and 64 who have underlying medical conditions. Now, boosters may be given to people who are younger, 18 to 49, who have underlying medical conditions, or people 18 to 64 who are increased risk of exposure and transmission because of their occupation or their institutional setting. So this would be people in jails. This would be occupations like healthcare workers or frontline workers or grocery store workers. And for these groups, they should look at the risk versus the benefit and decide whether or not they should get a booster. Next, and this is, again, only for Pfizer. Moderna is also working on a booster, and they will submit their information. I think they have already submitted their information to the FDA, and J&J is working on a booster, but they have not yet submitted their information. Finally, let's talk about safety at school. Next slide. We want to have, for schools to be as safe as possible, we want to use a multi-layered approach. So what are the layers? The first layer is masks. That simple thing, a mask, is very important at protecting our children. So masks for everyone while they're inside. But when you're outside, you don't need the mask. We now know that the likelihood of the virus being transmitted out of doors is much, much lower. Now, does that mean we should have a bunch of big, meetings out of doors where everybody's on top of each other? No. But we know that the likelihood of getting sick when you're out of doors versus indoors is just much, much lower. We also want people to maintain 3 feet and, when possible, 6 feet of distance. We want anybody who's eligible to get vaccinated, because we really think that's our best chance of getting out of this pandemic. Younger children who can't yet be vaccinated should be cohorted. Contact tracing is necessary, so we identify people who have been exposed. Isolation for infected people, so anyone who's positive should be isolated from other children, and then quarantine for unvaccinated close contacts. Now, a big question that comes up is, when are those younger children going to be able to be vaccinated? And Pfizer has already done the studies, and Moderna is doing the studies of children down to age 5 and children down to age 6 months. The Pfizer vaccine, they use about a third of the dose for children down to age 5, and it looks like it's going to be very effective. Pfizer says that they will have that information to the FDA probably by the end of this month or by the middle of October. So I'm hoping that by the end of October, we'll have a vaccine for the younger children, and that will make our schools even safer. So let's go to the next slide. So what I would like you to do is help us spread the word. The vaccines are safe, they're effective, they're free for all. And I hope that I've answered most of the questions that you have. And I want to thank you for your attention. And now I'm happy to take any additional questions.
Thank you so much, Dr. Fisher. You did indeed answer quite a few of the questions. And if you don't mind, I've got a couple clarifying questions. We had a lot of people email in advance, and I see that we have some questions in the Q&A and chat. So we will do our best to power through these. But on vaccines, we'll start there. Could you give us an update on the efficacy of the 3 different vaccines? Where that stands?
Sure. So the messenger RNA vaccines are, if you look at the 2 weeks after your second dose, the likelihood that you will get a severe infection and end up in the hospital or die from the infection is very, very low. So they are 92 to 95% effective against hospitalization and death immediately after you're vaccinated. Over time, we know that your immunity tends to drop, but then it gets boosted when you're exposed to the virus. The older you are, the faster that can drop. We also know if you don't have normal immunity, if you've gotten an organ transplant, if you're immunosuppressed because you're on steroids or some other medication, we know that you don't respond as well to the vaccine. So in those cases, you should get a third dose. It's not a booster dose. It's an extra dose to increase the chances that you will be immune, to get you up to that 90% effective. We know that in long-term care, those people are not as likely to respond. So their protection rate was about 75% right after they were immunized, and it dropped to about 50% after 6 months. So those are the basis for wanting to have a booster. But if we look at younger people who are healthy, it does not appear that their immunity wanes nearly as much. So yes, if you have a job or if you have any risk factors that put you at risk, you can get a booster, but it's not so important as it is for the older people and the people who are immunocompromised. And pretty soon we'll hear about Moderna and J&J. Now, everyone always wants to know, well, which one's better? Is Moderna better? Is Pfizer better? Is J&J better? There haven't been any studies that have done a head-to-head trial of one vaccine versus another. So we really can't say which is better. They were tested at different times in different locations with different variants being around. So they're all good. Right now, there's a booster available for Pfizer. I think within the next month or so, there will be boosters available for Moderna and J&J, but it's not clear that everybody needs to get a booster right away.
Now, is there any difference in the vaccines in terms of their efficacy with different variants, particularly with Delta?
So right now, all 3 are very good against Delta.
Okay, wonderful. Now, what is the update in terms of the peak of Delta? What do you expect in terms of whether or not that will ebb? Will there be a winter surge?
So in most places where Delta has come in and taken over, it's been about a 10-week period where disease goes up dramatically and then drops down. And if you looked at that, if you remember the slide of the disease in the US, that's looks like what is happening. What we don't know is what comes after Delta. You know, what will the next variant bring us?
Okay. There have been a lot of parents who have emailed in about what's going on in Israel and some questions about whether it suggests that natural immunity is more effective than vaccine immunity, and also questions about breakthrough cases. Could you give us your thoughts on that?
Sure. So if you look, you can find an article that says just about anything you want. So that's why when I talk about natural versus vaccine immunity, I can't be definitive, because some studies show that vaccines are actually better, but other studies suggest that natural immunity may actually be better than the vaccines. So the answer is we don't know, but we do know that if you have natural immunity and you get a vaccine, it boosts your natural immunity. So there doesn't appear to be a downside. I believe there was one study in Israel where there was, in certain people who got the booster, they had a more chance of getting it, but it was small numbers. And I don't think that anybody has concluded that you should not get a booster if you qualify for one, based on the Israeli data.
As you know, right now, our quarantine follows the CDC policy with respect to quarantine. So if you're vaccinated, you're exempt from quarantine if you're exposed. But if you have natural immunity, that exemption only lasts for 90 days. Can you speak to whether or not that's something the CDC is considering changing, if the immunity might last longer?
Yeah, I have no idea on that one. And it's a little unpredictable. So I'm not sure, I'm not sure that we have the enough scientific data to really be able to say for sure. While the companies are monitoring what happens to your immunity if you've been vaccinated, there's not anyone monitoring what happens to your immunity if you had natural disease. So we just don't have the same amount of information.
Okay. In terms of vaccine mandates, have you heard anything from the governor's office or the Department of Health in terms of whether or not they're likely to mandate vaccines for children?
I have not. I think, the mandate for teachers and for healthcare workers, certainly makes sense to me. I don't anticipate that there will be a mandate for students, but again, with COVID, you can't tell, and things change. If things changed and it really looked like a mandate was necessary, I have confidence that the governor would then do that.
Okay. Getting to the question of myocarditis, some families have written in asking if it's potentially better to only have one dose of the mRNA vaccine rather than the second to avoid the risks associated with that.
So here's the good news. One dose is pretty good, but not for the Delta agent. So for the Delta variant, you need both doses. So granted, one dose, much less chance of myocarditis, but you're not protected against Delta, which is the one that's circulating right now. So I would still recommend both doses for adolescents.
Now, do you anticipate the same risk factors for when the vaccine is approved for children under 12? Do you expect that there could be the same similar risk factors for myocarditis?
So one thing we know about the vaccines for under 12 is that the dose is going to be lower. I think that means that it will be less likely that that some of these side effects will occur, or that side effects may be milder. But we're really going to have to wait and see, because younger children react differently. Little children aren't just little adults. Yeah,
absolutely. One question came in about antibodies, and is there a way to know, especially with natural immunity, if there is a way to know that whether you have enough antibodies to make you protected?
Unfortunately, no. All of the tests that are commercially available measure different antibodies, and we don't know what a protective level is. So because we don't know the threshold below which you're not protected, we can't say whether whether natural immunity lasts for 12 months, 15 months, et cetera. It may, we just don't know yet.
Okay. Let's see. Another question that came in with respect to our quarantine policy, which you would also reference as a policy, that is it in fact safe for vaccinated individuals to be immune from quarantine given breakthrough cases?
So, we shouldn't be surprised that there are breakthrough cases. Nothing's 100%. So if you have a vaccine that's 95% effective and you vaccinate 1 million people, you expect to have 50,000 breakthrough cases. I mean, that's 5% of 1 million. So people have to remember that these breakthrough cases are not unanticipated. The good news is the breakthrough cases almost always are very mild cases and don't result in hospitalization or death. So I'm not too worried about the breakthrough cases. I wish there weren't any, but they're being vaccinated clearly. If you're vaccinated and you get the disease, it's a much milder disease than if you're not vaccinated. So you have many-fold lower chance of being hospitalized and certainly way lower chance of dying from COVID-19. But breakthrough cases are going to continue to occur. Now, they don't occur at a high enough rate that we need to quarantine people who have been vaccinated. The other thing we know from Israeli studies is that vaccinated people who have breakthrough cases, yes, you can detect their virus in their nose, but they don't remain infectious for nearly as long as people who are not vaccinated. So they're not as likely to transmit disease either. So that's why the difference in the quarantine if you're vaccinated versus unvaccinated.
Okay. A question from the chat. Have studies started with teens who have had COVID-19 that will follow them through life to see if they have effects later in life?
Not that I'm aware of. Those studies would have to be funded by someone. And the pharmaceutical companies obviously do their studies because they have a vaccine and they can show how long it's effective. But I don't know if people are out there looking at natural immunity. Hopefully someone will, though.
Okay. One question about the FDA advisory panel and some of their them advising for some classes of individuals to not get the booster shot. Could you elaborate a little bit on your thoughts
Sure.
on kind of what the risk factors are?
Sure. So it's a little bit like, why did they say should for some and may for the others? So when they say should, it's because clearly the benefits outweigh the risk. When they say may, it's because, yes, the benefits outweigh the risk, but there are more risks that you need to consider. And that risk for Pfizer is the myocarditis pericarditis. So for people closer to that 18 age range, 18 to 25, 30, that's the group in whom myocarditis pericarditis has occurred. Again, it's rare, but because it occurs in that age range, what the advisory committee said was, we can't say that you should get the vaccine. What we're going to say is you may get the vaccine, but you should consider your individual risks versus your individual benefits. So that's sort of where we are. I know it's most of us like things to be black and white as opposed to these shades of gray, but that's in the shades of gray range.
Okay. Another question, could you please clarify how the relationship between vaccines and variants is similar or different to the relationship between antibiotics and bacteria? Like, is there some type of relationship in terms of how the vaccines work and address different variants?
Sure. So viruses change just like bacteria change. The viruses they don't have cell walls. They're kind of a different microbe. The bacteria, though, also change. And just like some bacteria originally are sensitive to all antibiotics, over time, as they mutate, it's in their advantage to be resistant to the antibiotics. So these multi-resistant organisms evolve. So we've seen that with things like Salmonella, tuberculosis, Staph aureus. All of those usual bacteria do get resistant to different antibiotics. Fortunately, what we haven't seen is the bacteria get resistant to the vaccines. So, we have Haemophilus vaccine, we have pneumococcal vaccine. The bacteria have not become resistant to the vaccines. For COVID, for viruses, we know that the viruses may actually change so that the current vaccines don't work as well anymore. We know that best for influenza. We know we need to change the flu shot year to year so that it'll work against what's circulating at this time.
A question about masking. Is there a particular mask that's better to use? I know some families have cited studies about masks not working. Any thoughts on that in terms of how to make sure that it's effective?
Sure. Most of the masks really work well. If the mask gets wet, if it's wet through and through, it does not work as well. So, you know, in that case, you should throw it out and get another one. The vaccines that you can buy in the grocery store like this one, disposable ones, are fine. But also, if you use cloth masks, those are good as well. They should be washed. You're supposed to wash them every day. And we know that there are some people who like to double mask. So they use a mask like this on the bottom and a cloth mask on top of it. Is 2 masks better than 1? You know, you can show in some studies that it filters more if you have 2 versus 1. But you can't you can't say that it's actually effective in the real world. So there are not studies that look at how many people had a breakthrough case wearing 1 mask versus another mask.
Okay. We have time for one more question. I don't want to take up too much more of your time. We're so thankful that you've been doing this for us. But one last question in terms of planning out your flu shots, and if you're getting the vaccine, how long should you wait between these shots?
Thanks. And thanks for the question. There's no reason to wait. You can get your COVID shot and your flu shot on the same day. So when COVID vaccines were first being given out, they said wait 2 weeks before you get any other vaccine. Since May, they have stopped saying that. So now you can get more than 1 vaccine on the same day. So if you need 2 or 3 vaccines, get them all on the same day. Yeah, you'll have pain wherever the shot was, but for me, it's get all the pain over at once as opposed to having pain twice.
Wonderful. Well, thank you so much again, Dr. Fisher. We will have the recording of this available. We'll send it out to everyone in case you want to rewatch anything. You're also always welcome to submit additional questions to safety@ranaschool.org. We're starting an Ask the Head series where Dr. Griffith will be answering questions, particularly as it relates to school policy. And of course, we're grateful as always to Dr. Fisher and the Council of the Medical Advisory Board. Dr. Griffith, do you have any closing remarks?
I don't, Jennifer, other than, again, just to echo your gratitude for all the work that Dr. Fisher and others are doing to help support these protocols at school, and again, the compelling interest of school safety. So again, thank you to all of you for tuning in today. I'm sure we'll provide some additional notes. I think there were a couple of questions related to specific studies, Dr. Fisher, about masking and positive aspects of that, or perceptions of risk. So we can certainly provide specific studies that address those issues. But otherwise, I think it's been a great discussion, really useful information, and we can't thank you enough for all the work you're doing. Thank you, Dr. Fisher.
My pleasure.